See the recording? Yeah, okay, good. So these topics are today that we will cover are both related to the quality and accreditation and patient safety. And let me tell you, these three things are not separate. Patient safety, quality, as well as the accreditation, they go hand in hand. Improvement in any one of them actually leads to improvement in overall patient safety. Quality, in my view, is just a part of the larger patient safety universe that we speak about. And accreditation, as I mentioned in one of my previous discussions also, is a means to, motivate ourselves to achieve to some standard that we have voluntarily accepted that we will, achieve these standards, whether these are related to the infrastructure, processes, legal compliance, and the outcomes also. So patient safety to some extent we have covered in the last topic also when I discussed the medication management. And there might be overlap from the previous discussion and overlap between the two topics that we are going to discuss today also. That's the patient safety and quality in clinical and non-clinical domains and the accreditation part of that. So what is patient safety and quality are fundamental pillars of the modern healthcare. It is a commitment to protect patients from harm while delivering high standard of care. And you must remember in the very first interaction, I told you that hospitals, in fact, are one of the most dangerous places in the world. We go there to get treated, we go there for healing, but at the same time, we get, exposed to so many types of risks. These risks come from microorganisms. These risks come from radiation. This risk come from heavy, equipment that we use. This come from the pollution that we generate, the biomedical waste that we generate, the medicines that we administer. Some of them are very, very toxic, medicines. The radiation that we give to the patient. So there are different types of risks to which the patient gets exposed to while the patient either is visiting the outpatient department or is getting admitted or is some procedure is being done on the patient on a daycare basis. So that's why we, over the years, the patient safety movement has got traction because the first objective of a healthcare personnel or a healthcare establishment is to heal others, and as we said, first do no harm. We don't want to harm the patient while we are trying our best to heal the patient. And let me tell you, patient safety is not the job of the hospital administrator or the clinician or the nurse only. It's everyone is involved in this, including the engineering, including the sanitation, including the architect of your hospital, right? So without, let's say, HVAC, proper HVAC, your OT might not be able to provide you the temperature that is required to achieve the cases. For example, if it is a CTVS case, you need a much lower temperature in your OT. Similarly, for the ICU, you may not be able to achieve the level of infection control if your HVAC is not running properly. So everyone has a role. It's not just the clinicians or the frontline managers that you see. The linen that you receive from the laundry, the cleanliness of that linen, adds to the overall infection control practices that we follow. The technician working in the CSSD. Everyone has some role to do in the patient safety. As I mentioned, the patient safety and quality are not isolated. They result from a unified system-based approach. Clinical and non-clinical components work together to improve outcomes and reduce risks. And organizational culture, resource allocation, and process improvements are equally important. Now, here is our role as an administrator. Culture is very important. We sometimes say this hospital is good and this hospital is not good. we to some extent might be talking about the technical expertise of the clinicians in this discussion, but you would realize that a lot of it comes from the culture. If a hospital's cleanliness is there, if hospital systems are good, if hospitals staff are receptive and polite, they are not rude, if there are good signage systems are there, if the parking is good, if it has, good gardens are well maintained, the toilets are clean, this actually is telling that there is a culture. And if you go, if you find everyone is spitting here and there, and the bins are full of rubbish and no one has cleaned them, water taps are broken, the WC is broken, or the urinals are broken, and the water is seeping from here and there, you would say this is not a good hospital. But actually what you're telling us or telling is that the culture of the hospital is not good. And everything else revolves around this. And as a healthcare administrator or a hospital administrator, it is our responsibility to build that culture where everyone is working for the benefit of the patient. Every process, everything that we do, we keep the patient in the center of our universe, and then we think of doing the things, whether it is medication safety, whether it is building a new waiting hall for OPD, or in an indoor area, or designing a labor room or anything. It all depends on the organization culture. And the other things then follow, whether it is the resource allocation or the process improvement and others. QI principles, as some of them we discussed in one of the previous class, apply across both domains, that is clinical and non-clinical. So key areas, some of them are root cause of errors, culture of safety, role of technology, patient-centered care, risk management, regulatory compliance, and many others that we will discuss today. So patient safety is the prevention of errors, adverse events, and harm during healthcare delivery. In clinical domains, it could be in the form of preventing medication errors, ensuring proper surgical procedures, avoiding hospital-acquired infections, safeguarding against diagnostic errors, verifying correct medication and dose, maintaining a sterile environment, preventing falls, many others, many others. For example, surgical procedure I have already mentioned. Ensuring that the proper care is being provided in the ICU. And non-clinical domain is, it's whether EHR, whether it is electrical supply, whether it is safety of your civil infrastructure. You must have heard the incidents of ceiling fans falling on patients or attendants in the hospitals, or portion of a ceiling, a false ceiling, breaking and falling down on either the patients or others. Patients getting electrocution, fires in the hospital. So all these non-clinical domains are equally important when we are talking about the patient safety. Then communication systems, as I mentioned, that when handing over and taking over of shift is happening, that's the most crucial point where if not done properly, there are chances that something, some information, crucial and critical information, might not have been passed on to the next staff in the next shift, and could all lead to a potentially patient safety situation. So risk management is important. As a hospital administrator, we should analyze the risks proactively and try to fix them proactively. I don't know, some of you might have heard of the word HFEMA, that is the Healthcare Failure Mode and Effect Analysis. It's a way of doing the risk analysis in your organization, whether for a unit, for an equipment, for a service, for a process, or you want to do at a larger scale, you can do at a larger scale also. So identifying, assessing, and mitigating the potential risks that could harm the patients is important. It could be structural reasons, you assess structural risks. It could be risks related to the equipment used. It could be the risk related to some processes which are, high risk processes. For example, administration of chemotherapeutic drugs, or radiation therapy, or some type of a therapy in nuclear medicine department. And there are many others, high risk areas. So assessing those risks from the patient's point of view, from the patient's perspective, and then mitigating these potential risk hazards. So risk identification, then risk assessment, risk mitigation, and then monitoring and evaluation, continuous monitoring and evaluation is done, so that if there are some new risks or there are some gaps which are still there, you can, fill those. So I would strongly urge you people, whenever you have some time, you can read about the HFEMA. It was developed by the Veteran Affairs Department of United States and is considered as one of the very good tool for the risk assessment in your organization. Error prevention is basically risk mitigation, and right, you have identified a risk in the form of an error which can happen, and then you are actually preventing it. Or you have the system or processes where you have checks and balances to prevent these types of errors, as we discussed last time with respect to the medication errors. These errors could be surgical errors, So, for example, you must have heard many cases where some gauge piece or some other type of instrument that has been used in the OT is left inside the patient's body cavity. Or sometimes you must have heard that wrong patient have been, operated upon, or wrong part of the patient has been operated upon. So all these are errors, and these are preventable errors. As I mentioned, that medication errors, these such type of patient safety hazards are preventable errors, and for which we can have checks and balances. For example, to prevent surgical errors, we now have a surgical safety checklist, which was developed by the WHO, and it's very simple checklist. If rigorously implemented in your OT, it will prevent any type of such errors that can happen in the OTs. And standardizing the processes, automating the processes, and training and education of the staff is important, because many of these errors are human errors, and if you can automate them, some of the processes which have the human involvement, and if you can actually automate them and totally remove the humans, then there are chances that the processes might become more efficient. But in healthcare, we can't just remove all such processes. It's a highly technical job where the expertise of the experts is important. For example, a surgery is to be done. Even if you have the robot, you still need a human behind the robot. So, we just cannot automate everything, and that's why training not just once. It has to be a continuous training, reinforcing all the time, again and again and again, emphasizing on the importance of error prevention, patient safety, and providing the support to the staff, providing the resources, providing training, education from time to time and continuously, as and when needed, is important. CQI or TQM also we discussed in one of the previous lectures. Ongoing efforts to enhance patient safety and quality by systematically evaluating and improving the process. And safety is not a one-time achievement. You achieve something, then you improve upon it, you find some other gaps. For example, BDSA we discussed last time. The root cause analysis is another way. Once something has happened, you try to find out why it happened. And it is said that if you ask why 5 times, you would probably reach to the root cause. And if not, you keep asking why, and ultimately you will find out what is the ultimate root cause for an error or a mishap that has happened, or a patient safety incident, or a near miss. Even you can do a root cause analysis. Then you have data-driven decision-making, collect and analyze data on incidents, whether it is an infection rate, falls, medical errors, surgical errors, surgical site infections, etc. And then you make decisions. I can share a very small example on this. In one of our ward, the UTI COTI rate was very high, the catheter-associated urinary tract infection. And this was a female ward. And this was a obstetrics ward. So when we because the UTI rate was much higher than the other wards. When we did a root cause analysis, you would be surprised to know that the problem was not in the obstetrics ward. What was happening was many of the females were actually being inserted the catheter either in the OT or in the labor room, and during the lower segment cesarean section, and that insertion of the catheter was not as per the standard, and there were some gaps, and that was actually leading to the UTI. So once we identified it, we gave the training to the residents who were inserting, and then suddenly we found that immediately the UTI rate went down. So you do the root cause analysis, and you will be able to address many of these problems that you are. So it has to be data driven. You see a data that there is an increase in the UTI, and then you act on that data. Feedback loops. Staff at all levels provide feedback on safety concern to drive policy changes. And as I mentioned in one of the previous discussions, also it has to be a no blame culture. Then only staff would be forthcoming and give you the feedback. And just being open is not enough. Let me tell you, you are open to feedback and they are giving you the feedback. But if you are not acting on that feedback, then also people would not continue to provide you the feedback, because they would know even if I'm telling them, they are doing nothing. So if that becomes the reputation of a hospital administrator, then also people would hesitate to provide the feedback. As I mentioned, patient safety and quality are linked to each other. Improvement in one actually leads to improvement in another, and they are parts of the two sides of the same coin. So some of the clinical domains that we will discuss that are mentioned in the manual also. Clinical safety. Clinical patient safety is a cornerstone of quality care, ensuring patients are not harmed during care. Crucial in medication administration, surgical procedures, and diagnostic accuracy. Now, diagnostic accuracy is very important, let me tell you, because what happens that if your diagnosis is not correct, what you are doing is you are doing harm to the patient if you are giving him treatment for something else that he is not suffering from. So diagnostic safety is important, and it's not just the diagnostic safety in terms of the diagnostic reports that we receive, whether it's report of the blood sample or some radiological procedure or some other procedure, but the clinical acumen of the physician and surgeons in interpreting those findings and arriving to a correct diagnosis is important. And not prescribing or advising a proper diagnostic procedure required in that situation is another problem in diagnostic accuracy. I have seen many a times this problem more prevalent in the super specialty hospitals, because they have become so super specialized that many a times they just have a tubular vision and they want to see the patient's problems only in the domain that they are working, or the specialty that they are working. And they just don't, many a times, are not able to see beyond that, and patient might be suffering from something else, whereas they continue to give treatment because they think that, okay, from our perspective, this is the diagnosis, and this is more common than we think. So it's always, I always say, it's never a bad idea to take a second opinion, especially if it is a chronic situation. Key elements on clinical safety include evidence-based practice, using best available research for clinical decision making, effective communication, clear and concise communication among providers and with patients. I think I mentioned in previous that patients play an important role in quality, in patient safety, in medication management. And nowadays youngsters are becoming more and more proactive, and and they want to get involved. And they have resources also where they can cross-check whether you are providing correct information or not. Teamwork and collaboration, working together to improve care, patient-centered care involving patients in decisions, tailoring care to individual needs, risk management, identifying mitigation and mitigating risks, quality improvement, patient safety culture. As I mentioned, there might be a lot of repetition what we have already. Medication administration safety, I think I have already covered in detail, so I would not go again and would not discuss again. Surgical safety, very important, because it might lead to a situation which is irreversible, right? You have given a wrong dose or a medication, patient still might recover from that. But for example, if you have amputated a wrong foot or a wrong finger, or have operated upon a wrong limb, then it could be an irreversible situation. So that's why surgical safety is very, very important. So WHO surgical safety checklist, I have already mentioned, it confirms patient's identity, surgical site, and procedure before, during, and after the surgery. Reduces wrong site surgeries, anesthesia issues, and post-operative infections. Anesthetic agents are again, high-risk agents. Proper administration and monitoring of patient while patient is under anesthesia is very important, right? And use of good quality anesthetic agents in hospital is important. Timeout procedures, brief pause before surgery, team confirms patient ID, procedure, and the correct site. Infection prevention point of view for surgical safety is sterile techniques, prophylactic antibiotics wherever needed. You don't have to give prophylactic antibiotics for all surgical cases. It's not required. Only for specific cases with specific indications might require prophylactic antibiotic. The indiscriminate use of antibiotics is another problem, and we should, discourage it. The use of antibiotics should be evidence-based, and rational use of antibiotics should be there. Proper hand hygiene, sterile drapings, and many other aspects related to the infection prevention. As I mentioned, it could be an engineering aspect, right? It could be equipment-related aspect. Even the oxygen, medical grade oxygen that we give to the patients, if it is it's not medical grade oxygen, or if its quality is poor, it could lead to patient safety incidents. Team communication, very important. Clear handoffs during shift changes, appropriate delegation, and effective problem solving is important. Diagnostic accuracy, again, standardize the diagnostic protocols, second opinion and peer review, take the second opinion. Technology and decision support tools, CDSS and EHR allow quick access to patients' data, reducing misdiagnosis. Nowadays, there is a lot of what we call the polypharmacy. And polypharmacy in the form of not just the allopathic treatment, but the patient might also be taking a treatment from some other pathy. It could be homeopathy, it could be Ayurveda, or someone else, something, advised on WhatsApp, and nowadays people start taking that. This also adds another layer of complication for diagnostic accuracy and the therapeutic, from the therapeutics point of view. Because many of those, formulations that they are taking might interfere in the diagnosis when the blood sample is being examined. So patient must, tell all these things, and if there are some interactions, those must be examined. Involving patients, that's why I'm just saying, ask patients that if you are taking some other type of drugs, then let us know, and document it that the patient is taking these drugs, right? Team communication and coordination, medical errors often occur because of the communication breakdowns, handoffs and transition of care, multidisciplinary teamwork. Another thing is, many times you would find that some of the, not everyone, especially the surgeons, they are high-headed. They just, are not good sport. And historically, this is like this in the medicine, and slowly it is changing, but will take some time. And this leads to some type of, communication barrier between the resident and the consultant, between nurse and the consultant. especially in the surgical department. So how to handle that, how to ensure that they are receptive and they are listening to what patient is telling them. Many times they don't want to listen to even the patient because they think you know nothing, right? So you don't tell me. So I'm doing the best for you, which is not the correct approach. So team-based care, regular team meetings and case discussions to identify risk early, patient communication, and patient must understand treatment plans, medications and follow-ups, and patient education at discharge is essentially especially critical. More so if the if the patient is still not ambulatory, patient is depending on others, it's an old age patient, patients of stroke, so attendance education is equally important, not just the patient, but the caregivers education in that regard is important. So common causes of clinical error, as I mentioned, communication, lack of teamwork, fatigue and burnout. It's important. And, many a times, especially in the government sector, not enough emphasis on this aspect to address the fatigue and burnout. Nurses work 40 hours a week. They don't work beyond that. But residents are working much longer. The faculty are working much longer. Some other category of staff are working much longer. And in private sector, even nurses might be working at for long hours. So this also is an important aspect, human aspect, which leads to some type of patient safety incident. So that's something we have to address, because this ultimately leads to human errors, mistakes, lapse in judgment, or forgetfulness. But as I mentioned previously also, even in those situations, we have to look the larger picture. We should look from the system's perspective, and rather than finding faults in individuals. Healthcare systems are becoming more and more complex, right? Becoming very complex nowadays, and different types of equipment we are using, different types of medications we are using, so many consumables, so many types of procedures. It's becoming more and more, technical now. So the more complex it becomes, the more chances of mishaps or mistakes are there. Then if the processes are not designed properly, they are poorly designed processes, then leads to problem. Medication errors because of incorrect dosing, administration, prescription, we have discussed in detail in the previous class. Surgical errors we discussed, non-adherence to the treatment plans, patients are not following the advice, then leading to some type of a complications. Equipment malfunctioning, human-machine interface issues, or sometimes even issues that are beyond the control of your hospital. I remember once Northern Grid was failed, and suddenly we were facing with a situation where there was no electricity in the whole of the North India. Right? So how to manage the patients, specifically those who are on the ventilators? And depending on the size of your hospital, there might be hundreds of patients who are on the ventilator. So, and then you have to provide the water supply, and then you have to ensure the supply of the continuous supply of diesel for the gensets that you are having, and you are running them 24 hours until the northern. So these are rare situations. But when we are doing the risk assessment for your hospital, we also should keep in mind these type of rare situations that might happen, and how will you be responding to those situations if ever those things happen. What should be the strategies to prevent clinical errors? I have discussed is just a repetition, improving communication, teamwork, reducing the workload, implementing the proper systems, enhancing the education of the, improving the patient education. And let me tell you, empowering the patient is not a one-time affair. That patient was there, you once educated him or her, and you thought next time you would be much more informed. Because there is this power mismatch between the patient and the provider and the healthcare system, due to which the patients hesitate a lot, to question the provider, to provide feedback to the provider. And this requires continuous dialogue with the patient. And then only they will be, open to tell you mistakes, or even, inform you if they see something which is not normal. Promoting a culture of safety, it takes time and a lot of energy. So non-clinical domains are resource allocation and staffing, regulatory compliance and accreditation, safety culture, leadership commitment, policy development and implementation. For example, whether or not you have a infection control policy of your hospital, disaster management policy, whether or not you have a hospital infection control committee, and many other things for adverse event reporting, whether it is a manual reporting or an online reporting, whether it is anonymous reporting or not. Resource allocation, crucial, both resources in terms of human resource and the other resources that are needed. Regulatory compliance, if you are compliant to the various statutory provisions and the legal provisions, you are taking care of so many safety aspects with respect to the patient safety. For example, if your building matches the National Building Code, then you are complying to one regulatory requirement. And there are so many others then. Facilities management, cleanliness and infection control, environmental safety, from the fire safety measures, smoke detectors are working, your sprinkler system is working. Periodically, you are, testing them. Your fire exits are open and are not blocked. And not just this, your fire hydrants should be charged. Your, storage tank should have the water all the time, right? Your, alarm system or your communication systems that are there to report fire incident should be, functional 24/7, 24/7. Similarly, fall prevention, risk of fall, fires and injuries increase if there are poorly maintained facilities, or even poorly designed facilities that you are maintaining properly. Safety of medical equipment and supplies, very important. For example, whether it is a high-end equipment like an MRI or a linear accelerator, or a very small, for example, a defibrillator that you are having in your ward. If the defibrillator is not properly working, or if the staff doesn't know how to properly work, could lead to electrocution of the staff that is using it. So, safety of proper storage of medical equipments, right? That is also important. IT and health information system, electronic health records, centralized accessible record of medical history, diagnosis, treatment, and medications, reduce medical errors, different type of errors or incomplete or illegible record, facilitates tracking of patient progress, integrated with the CPOE to alert clinicians to drug interaction, allergies, contraindications, real-time alerts for lab results, abnormalities, vital sign changes, or diagnostic test results. Then clinical decision support system can be integrated in your HIS. And the data security and privacy, cyber security is very important nowadays. And we have very sensitive data, and there are bad actors in the society who want to have access to these data and want to monetize, or for whatever their intentions, they want to have access. And hospitals are easy targets for them, because majority of the hospitals in the developing countries do not pay attention to the proper keeping your systems up to date with respect to the cybersecurity. So that's one of the reason you will find a lot of sensitive patient data in the dark web, that is called. Requires robust encryption, not just encryption, let me tell you. Encryption is needed, at the same time training of the staff is also needed, that even after all this safety mechanism, if suspicious email lands in your official email or in your system, how do you identify that phishing attack, and you do not click such you know, links. Hospital operations and patient flow, reducing the waiting time and overcrowding, bad management, discharge planning. Many of the government hospitals, you would find that there are bugs in the beds, which is not a good situation, right? It's because of the poorly maintained hospital beds. Proper discharge planning and the care transition is important. Whether it is transition from ICU to SGU to general ward to discharge, home care, this care transition is important. What are the challenges and barriers to improving patient safety? Resource constraints, specifically in the government setup, you would find, uh, uh, and it might differ from state to state. Some states are very good in healthcare services and they might have good resources, whereas the other states might not have that good resources. And in any case, the overall public expenditure on the healthcare in this country have always been, less than what we would like it to have, for different reasons, right? So resource constraints are always there, and specifically the well-trained, qualified, and having a good attitude staff which is having an positive attitude. Um, that's very important. Then people are resistant to change, right? Some people are high-headed. They think that no one can teach us, whereas others do not have this problem, but they are still, uh, don't want to change because they are living in their, comfort zone. So then that's why healthcare administrator's job becomes even difficult, because we are dealing with humans, right? So uh, change management is entirely a different domain, and we have to be good in managing the change. Inadequate training and education also leads to such type of barriers and problems. Lack of clear accountability and leadership. As I mentioned, leadership earlier also, in previous class, leadership makes a difference. If leader is proactive, uh, have good approach, is accessible, listens, provides you resources, then things improve. But if the leadership is not proactive, then it becomes a barrier. I think this is the last one. Okay. So how do we take care of these barriers? So integrating safety into organizational strategies, and it takes time. It takes over the years. You can do it, and sustaining it. Once you have done it, sustaining it is even more crucial. So embedding safety into organizational culture as a core value, allocate adequate resources for safety initiatives, promote collaboration across clinical and non-clinical teams. You must have seen that even one arm of engineering would not be, talking to the another arm of engineering. For example, civil engineers do not communicate with the electrical engineers. Electrical engineers are not communicating with the HVAC guys, and it's common in the clinical setups also, right? So identifying those things and then trying to change the culture. Leadership and accountability, I have already emphasized enough. Training, education, simulation-based trainings, leading by example, or creating some type of positive competition between the areas, between the wards, between different, staff groups, um, rewarding the um, positive behavior, positive outcomes, uh, so that others can see that behavior, and then reinforcing that behavior. This also helps. So thank you very much. That was regarding the unit 15. Before I move to next unit, you are welcome to ask any questions, comments, if you have.
Good evening, sir.
Yes, good evening, Colonel Pandey. Please go ahead.
I just want to thank you for your lucid presentations, and I think everything was clear. So though there not much ambiguity. But one thing that day you said that 1 in 10 patients have some medications error or safety errors in the developing countries. And that figure I came to know from the books that is 4 in 10 in India, sir.
Oh,
And only
and,
this book,
and which book is this one?
IGNOU only.
Ah, okay.
Sure,
That's
sure,
a high
sure.
number. So which
So
study they have quoted? I mean, they must have some reference for this.
that I'll let you know, sir, after
Okay, sure, sure, sure,
going
sure.
deep into it.
I have the manual. I can also check. And
So,
I apologize. The two questions you asked about the transfusion medicine last time, no? I couldn't get the time to find answers to them, but I'll do and I'll share with the class. Okay.
no, that was simple one, sir. Like, what are the blood fractions which are being produced? So, you inadvertently missed that platelet part. Platelet concentrate is also made out of that. And I suppose the second question was about the screening of blood. That is not only being done by ELISA anymore. Now the chemiluminescence immunoassay is there, so that is more accurate. So that's why I had told you that day, sir.
Yeah, yeah. But someone had asked about the
Yeah, yeah,
transfusion.
yeah. Wow, yeah, yeah. She said that the blood is expiring on the same day,
Yes,
and
yes.
that is in the middle of the night, whether it can be transfused or not.
Yeah, yeah. So I'll find out because I was so busy I couldn't actually connect with my friend. So I'll find out. Okay, so again, I'm not able to share. I'll just log out once and reconnect. It's not allowing me to share my PPT.
No problem, sir.
I don't know what happens. This happens every time when I'm sharing the second one. The Google doesn't allow me to share it.
Sir, this is on page number 167, sir.
Okay, okay, I'll check.
Of volume 2 only, which says that in primary and ambulatory settings, nearly 4 in 10 patients experience harm, with most of this harm being avoidable.
Okay, okay, thank you. The problem I am facing right now is that the window is not sharing. I'll share this. I don't know what is visible or in this if I share this.
It showed for a brief time, sir.
Yeah, but then something happened and I was not able to scroll that.
Okay.
Just give me a moment. Hmm. Is someone from IGNOU here?
Sir, or you can share this with Dr. Madan and
Okay, okay. Can you see now? Is it visible now?
yes, sir.
Okay. And it is not visible to me, but at least it is. If it is visible to you, then that's fine. Okay. Okay, there is some issue probably. Let me see if it allows me to scroll next. It's changing.
Yes, sir.
Okay,
Yes,
okay.
sir.
It's not allowing in the presentation mode, but I'll share in this mode. Okay. Okay, sorry for that. Okay, so the next I want to discuss, and as I mentioned, there might be a lot of overlap when we discuss the accreditation, because we have discussed accreditation in the previous class as well, and a lot of it we have discussed while discussing the quality also. So patient safety is a prevention of harm to patients during healthcare delivery. WHO defines as that identifying, preventing, and reducing risks that could cause unnecessary harm. Healthcare delivery is complex. We discussed nearly 1 in 10 patients, and as Colonel Pandey mentioned, 4 in 10 patients in this country are being harmed while receiving the care in the hospital. And examples we have discussed several times. So IUM framework, I also mentioned. IUM framework is basically the Institute of Medicine United States that came up with the seminal study 2R is human, and after which this patient safety movement got the traction, and nowadays we discuss a lot about the patient safety, improving the patient safety, improving the overall performance of the hospital. This also we have discussed, I guess. Accreditation. So accreditation, you all know, we have discussed the formal process in which external organizations, assessors assess healthcare facility to ensure they meet the predefined, standards, quality standards, and recognized safety standards. Think of it as a seal of approval, an external approval that assures patients and stakeholders that a hospital is delivering care is based on the best practices. Hospitals with accreditation report significantly fewer adverse events compared to non-accredited hospitals. In this country, even the non-accredited hospitals do not have the this compulsion to even report the adverse events. Sometimes they are reported, sometimes they go unnoticed. So, but at least it is a belief, or it is a fact actually, that after one hospital gets the accreditation, the chances of adverse events goes down, provided that they are maintaining those standards even after the assessment has been done. And it should not be like during the assessment period only they, are the showing the best foot forward, they are putting best foot forward, and later on they are not able to maintain their standard. So then it would not help. So purpose of accreditation is to standardize healthcare processes, to enhance patient trust, to promote ongoing quality improvement. There are so many organizations in different parts of the world which provide accreditation. In this country, it is the NABH and the NABL, two main bodies under the QCI, the Quality Council of India, which are providing the accreditation for the hospitals as well as the laboratories. In addition to that, the international arm of the Joint Commission, that is known as Joint Commission International, also provides accreditation to various hospitals, and many of the hospitals in this country have the JCI accreditation along with the NABH accreditation because it helps them in getting the international patients also. So JCI is an international arm of the Joint Commission, which is operational in many countries. And as I mentioned last time also, that there is an organization called ISQA, which accreditates the accrediting bodies. So whether these accrediting bodies are meeting a standard or not. So for example, NABH is accredited from ISQA. The accreditation process also we have discussed in last time, or maybe the first or second class, but in short, it is a self-assessment. Then you find the gaps, you plug the gaps, that you implement the improvements, then you apply for the external review. Surveyors come, they submit their reports. If there are some issues, they will, ask you to, it comes as an NC, the non-compliance. You work on those non-compliance, you submit your non-compliance and convert them into the compliances. And then finally, if you are meeting those standards and if the accrediting agency is satisfied, they will give you a certification for a particular time period, that for this time period you are accredited for these services or for these standards you are accredited. And then you can use their logos also in different types of your branding that you do. You can use their logos. And then most important in my view is that you do ongoing monitoring, continuous evaluation to maintain those standards, maintain that level of quality. So how accreditation helps? Understanding accreditation helps healthcare professionals improve patient safety, gain global readiness, enhance career growth, develop problem-solving skills, and you become more patient-focused. Right, your approach changes when you know that these are the standards that you have. Not having those standards, actually you are working in an environment where there are no standards or there are no benchmarks that you have to meet. You may be providing best of the care. You are not providing any inferior care. But knowing it that you are meeting a benchmark, that you are reaching to a particular level, whether it is in terms of outcomes or processes, it helps and it increases your confidence as well. And it increases the confidence of the patient as well. So how it helps the patients is that the patients now have a better confidence in you and your organization. Key standards and frameworks. Most accreditation frameworks rest on 3 core pillars: governance and effective leadership. Now I believe we have the 6th edition of the NABH standards, if I'm not wrong. And then there are different chapters, and in those chapters there are different editions. 6th or 7th, which one I'm not sure, maybe 7th.
6th, sir. I'll forward it to you also today.
Okay. It's a 6th one. Okay. Thank you. Patient-centered care. Patients are informed. Participants' rights are upheld. Communication is open and respectful. Then there is continuous quality improvement, evidence-based decisions, data-driven outcomes, and ongoing audits. Strong hospital leadership is directly linked to, improved quality, including the lower adverse events and improved staff morale. And this has been proved study after study and study after study that hospital leadership plays a crucial role in the quality of the hospital and the patient morale, the staff morale. because staff when knows that if something goes wrong and the leadership has my back, then their approach to the to the work changes, and then they are more willing to go beyond the call of their duty and do it for the patients. It doesn't become a mechanical transactional relationship where they come, they work, they get the salary, they go home, and that's all. It's the leadership which actually makes sure that the staff is subscribed to the mission and vision of the leadership, mission and vision of the hospital, and then they work together to achieve those objectives. Patient-centered care standards, NABH has incorporated specific patient rights and empowerment standards for India's healthcare landscape. Now, patients have rights as well as they have responsibilities also. So both goes hand in hand. While one hand, patients have their rights, for example, right to know the treatment, right to know the name of the provider, right to know what drug is being given to me, and many others. At the same time, they have some responsibilities also, that they will follow the instructions that have been given by the doctor, right? They will be, open and honest in telling the history of the ailment and many other things, personal history, drugs history, or others. So rights and responsibilities go hand in hand. Core dimension is accreditation framework or governance, infection control, medication management, facility management. There are many others. So if you go through the 6th edition of these NABH standards, you will find there are chapters which make the main pillars of those framework, on which there are then different other parameters on which we assess the organization. Evidence-based tactics and continuum of the care or the continuous quality management is another standard that require hospital to base clinical decisions on scientific evidence. ISCO emphasizes data-driven practices, analytic help track outcome, monitor adherence to guidelines, and identify areas for improvement. What are the various key elements of evidence-based accreditation? Use of clinical pathways based on evidence, regular clinical audits, performance monitoring dashboards, data-informed decision-making. Global accreditation bodies, I have already mentioned, there are different for those different countries. There may be more than one for different types of services in a country, and there are some international ones which may be providing accreditation. Even there are bodies which I'm forgetting the name, for accreditation of the nursing services in the hospital. There is one in the US. I'll get back to you because I was involved in that, but I'm forgetting the name of that accreditation body. It is done for the nursing services in the United States, in addition to the Joint Commission's accreditation. NABH, we have already discussed. These are some of the global accreditation bodies. And then there is like ISO certification, which is not accreditation, but is a certification. Accreditation is actually telling you, the quality of outcome they are kind of accrediting. Whereas certification mainly is certifying that the processes are in place. So that's the main difference. So the ISO is basically a certification and not the accreditation. Benefits of accreditation for patient safety: reduces errors. We keep repeating this. Prevents infection and adverse events.
Sir, actually, the first slide had come back again.
Which one?
Not the regular slide showing. It is the start slide had again come, the first one. Accreditation perspective of patient safety.
Okay. So you are not able to see my current slide, right? That's what you're telling.
Yes, sir. Yes, sir. Yes, sir.
Okay. Technology sometimes works like this. I'll try to do it again. Are you able to see the current slide now?
Yes, sir. Yes.
Okay, good.
Sir, what is the difference between accreditation and certification?
So, as I mentioned, it's accreditation is basically kind of a, it's telling you about that the outcomes are to a certain standard. Whereas the certification is just certifying that the processes are in place. So ISO, you will never hear the word ISO accreditation. So you will always hear ISO certification, which is not accreditation. Accreditation is basically kind of you're telling you that there are standards predefined, you are meeting them, and because you are meeting them, there is a surrogate way to tell that the outcomes are of quality. Whereas the certification tells you that, okay, here is a system in place for this type of a service. So mostly we use it in the production industry where something is being produced. We use it in service industry also, no doubt about that. But this is only telling you that these processes are in place. So you should be not confusing the certification with the accreditation. Okay. So benefits of it.
Hallmarking of the gold, sir, is that certification, BIS certification?
Yes, this is certification. So it is telling you that the gold that is being claimed is of that quality, right?
Yeah, so Salini will understand better now.
Yeah, correct. Whereas in accreditation, because it is patient outcome, we can't, say directly all the patients you're getting the outcome, but they are meeting to some standard. Their standard have been fixed and they are meeting it, and then it's accreditation. Then there is another word I am forgetting, accreditation, certification, and मुझे याद आता तो मैं बताता हूँ, ठीक है. It's not in the IGNOU probably because I prepare these slides based on the manual, but there is one more word, accreditation, certification. I'll get back to you again. Okay, so benefits of accreditation. Reduce error, prevent infection and adverse events for the healthcare quality, promote evidence-based practice, improves communication and teamwork, enhances patient satisfaction. Benefits to the healthcare workers, provides a clear process to follow. There are standard operating procedures. They have defined roles and accountability frameworks. Ensure uniform care delivery across teams and shifts. Build professional competence and confidence. Their professional development is being taken care. Encourages ongoing learning and skill enhancement. Boosts staff confidence. Improves job satisfaction and growth through training and mentorship. And the staff satisfaction level is also high in those organizations which are accredited. Building a safety culture, I have already discussed. Leadership, I have already emphasized enough. Training, even the accreditation bodies have these standards for training, how often you are performing those trainings, how you are evaluating those trainings, and if you are not evaluating, then you are not meeting those standards. Root cause analysis, a systematic process for identifying underlying causes of an adverse event or near miss. RCA goes beyond surface level mistakes to examine system-wide factors. It helps facilitate to identify and analyze events at a system level, develop corrective actions, track progresses, and share learnings. Challenges and accreditation are almost the same that are for the quality, implementing the quality or the patient safety. High accreditation fees, it is mentioned, but fees is not that big a problem. It is the infrastructure cost, but that in any ways, hospital is expected to invest if hospital wants to provide a level of quality, right? That cannot be compromised. And having a level of staff, right? of a particular skill. You just cannot, substitute a medical officer with a, officer with some pathy. That, in my view, is not a good practice. That is happening in many of the hospitals in this country, right? But then, if you want to provide quality, then your staff should be knowledgeable to that type of apathy that you want, that you are practicing in your hospital. If it is a, nowadays there is a approach, there is a concept of integrative approach, where you are providing yoga also, you are providing Ayurveda also, and that is fine. If that is the approach, that is still fine. But if you are a, allopathic hospital and you are deploying some other types of medical officers which are not well versed in the allopathic therapy, then that's a problem. So investing in that is important, whether it is an infrastructure or the staff. Then only you will be able to, maintain the processes, provide those processes, etc. Infrastructure gaps, EHRs are very costly. Infection surveillance, data tracking is not always feasible. Okay, yeah. There are resource gaps are the leading barriers for safer healthcare in Pakistan. Another is the leadership. If leadership changes, or a leadership of not just the hospital at the top level, but the leadership at the unit level also, you will find that some wards are performing better than others. Why? Because the nursing leadership is good, or their consultants of that ward are taking interest in quality, taking interest in hospital infection control, taking interest in the medication management. Whereas in other ward, either the consultant is not taking interest or the nursing leadership is not taking the interest, and then it becomes a barrier. The solution is focus on foundational practices, create international partnerships for funding and technical support, use low-cost technologies, open source softwares. But again, I would not advise to use open source software unless you are technically sound. The system is technically sound enough to withstand the cyber security attacks. So there are always pros and cons. Adopt a phased implementation approach to manage costs and ensure a steady progress. That's fine. Resistance to change is another thing, and that I always say that if the tawa is garam, if it is a hot plate, you don't catch it from the hotter side. You always catch it from the cooler side or from the wooden side. So same logic applies, or the same approach applies in the change management or the conflict management also. Always, create a critical mass of people who are ready to change, right? And focus your energies on them. And then you will be able to do at a larger level. And start with the carrot, and many times in government setup, you might have to use a little bit of stick also. So don't hesitate to discipline people where there are incrucible ones. So not everyone is resistant to change, but as human beings, the first instinct is always no. You would find people don't want to see many in a larger picture because they don't want to come out of their comfort zone, right? They see sometimes that, oh, this is an additional work. Don't give additional work when you want to improve the quality. Try to do within the work domain, and if they are subscribed to your idea, and don't make it your idea, sell them in a way that where they are saying, okay, this is our idea, we want to do it. Ask them, how do we improve it? And then they will tell you, oh, we can do like this. And once they are saying we can do like this, then it becomes their responsibility, right? Because they have subscribed to it. You just can't advise and then think that someone else will do it. My boss, one of my previous boss used to tell that everyone in this world wants to work, but in an advisory capacity, right? Aapko ye karna chahiye, you should do this, you should do this, you should do. That's not how it works, right? Whosoever is advising also have to chip in also. So once they are telling it, it's kind of an obligation on them to then now work towards achieving that. So maintaining standards post accreditation is very, very important, because you just cannot relax once you have achieved the accreditation. You must ensure that resources are still being provided at the same level, or even at a better level. Better resources are being provided, human resources being provided, they are being monitored properly, proper reporting is being done, satisfaction levels are not going down, etc., and many other things as per the standards that you continue to monitor. Open and honest communication across all levels and disciplines is key. And as I mentioned earlier, it's not just the communication. Once you have received the feedback, you just cannot, sit idle and say, okay, I have received the feedback, but I'll work upon it maybe later. That's not how it works. If there is a feedback, if something has to be done about that, and if something you are not doing something, you have to communicate why this cannot be done at this moment, or it will not be done, or something else is being done, or why this feedback, although welcome, but may not be feasible to implement. So you just cannot sit idle on the feedbacks, and because later on what will happen, people will not give you the feedback. Encourage transparency, support team collaboration, promote structured tools, briefings and debriefings, etc. Non-punitive error reporting is important, right? So as I mentioned, it has to be seen from the system's perspective. Errors happen, but can be prevented if the checks and balances are working, right? The error leading to a harm can be prevented at several levels, right? It's only when the multiple checks and balances fail, the error leads to some type of a patient harm or a near miss. So it's important that people, you have the monitoring mechanism for at least for the critical systems, where you ensure that the people are following the checks and balances. For example, the surgical safety checklist. It should be implemented, religiously in all the operation theaters. That is what my view is, and we do it here in our organization. It is a simple, low cost. There is no cost, in fact, tool which prevents surgical errors. So implementation of these religiously and rigorously is very important. So a culture that does not punish staff for reporting errors is critical. Benefits of non-punitive reporting: staff feels safe sharing near misses and incidents, shift focus from blaming individuals to improve systems, enables identification of recurring problems, builds trust and morale, increasing participation and safety. Example is, instead of punishing a nurse for wrong dose administration, the organization reviews labeling, barcoding system to eliminate the future errors. Automation, some things you can automate also. Key actions to build safety culture: staff-wide safety training, cultural surveys, celebrating safety success because it motivates others, patient involvement in care. Also, when a staff is working in your organization, then it becomes a family. So finding ways to congregate families also, their families, and how do you develop that kind of a culture where the colleagues know each other's family, and even once in a while it could be a festival or something that you gather everyone, and then even at a unit level, not necessarily at an organizational level, but at a unit level or at a departmental level, and celebrate successes, share stories. This bonhomie between the staff, between the leadership and the staff, between the unit head and the staff, it is a very crucial and important aspect. And if you see the why there is difference in quality or performance of two units or two departments, you will find that one department has a better working relationship with their faculty, or the staff know each other's kids, they are their friends, or they know how they are progressing in their personal life and professional life. Whereas in other, they just come, work and go, and there is no bonhomie. So these are like soft parts of the intangible things that we also needs to take care, and they actually adds to your better performance and better satisfaction of your staff. So thank you very much. That is all from my side, and I hope these classes were useful for you. And if there are any questions, comments, any experiences you want to share, you are most welcome. And I also want to say that I am open to feedback in case you want it to, for the next batch, you want something me to change or improve, how I can, make it better for the students. If there are something, you can give it to me separately, not necessarily right now. You can give that feedback to my email also, or to the, I'll share my email here. I am open if you have any feedback on my teaching. Share.
Some more classes from you, sir?
Say again?
Some more classes from you?
Maybe if they, I think some of your classes have not been taken by Dr. Sameer, I am told, and because of his commitment. And there are some classes for which I think there are no counselors yet assigned. So, IGNOU will look into it, and I am open to whenever I am available. I am more than happy to take classes.
Okay, sir. Okay.
Thank you.
In fact, I shared Professor Jawahar's number long time back. He had taken one class.
Okay.
He is from AIMS Bhubaneswar.
Yes.
You might be knowing, sir.
Yeah.
So, but there was no action from RC2 side. RC2 Delhi side.
Okay.
So, this also, in fact, I requested for the previous session, there was no class at all. So
I think Dr. Jawahar might be busy, so it could be from Dr. Jawahar side also.
Initially, he was available. He said, I am free, but I have no communications from IGNOU. So I cannot say.
Okay.
So no problem, sir. Whatever happens, obviously we'll anyhow we'll have to make to the exam. We'll have to sit over there.
All the best to for your exams. And
thank you, sir. I have already shared the 6th edition of NABH to you.
Okay.
On your WhatsApp, and it is.
I have it because it is available on their website. Thank you for sharing it.
And on the website, they don't give the full version, sir. So,
but this is somewhere available. I think someone has uploaded somewhere. If you search it.
January 20 last year it was released, so it is a new one. No further edition after that.
Okay.
Really enjoyed, sir, working. Having some classes with you and interacting also.
Thank you, and I also appreciate your active participation, and everyone whosoever has participated. So thank you very much, and I wish you all the best for your exams and for your career. Thank you very much. Any other questions? Any questions you have? No. So okay.
Hello, sir, just one question regarding this research. Regarding research, they will take classes or not, sir?